Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. Let's talk about getting that radiology, that radiological equipment in your new office, assuming you're a new grad or you're purchasing a new office. I get this question a lot. What should I buy if I think maybe one day I might want to start doing some ortho? And they're thinking, shoot, I'm going to need to get a pan. I'm going to need to sometimes get a Ceph. And that whole Ceph thing it really just depends on what type of cases you're taking. Let's put it this way. If you have no way of getting any Ceph from a CBCT, from a neighbor, from another office, from a clinic, from a center, from anywhere, you're in the middle of nowhere, middle of nowhere in North Dakota, you have no way. Well, then you're going to have to get one. But like I've told you guys, we have several offices. We don't have a PanCef in any of them, nor do we have a CBCT, but we have places to go within a mile or two that are very convenient. Nobody cares. The billing is easy and it's not a problem. So for us, where we are, where the overhead is and the cam is super high, it just makes more sense not to have one. But for most people in the United States, it probably makes sense to have one unless you already have a traditional one in there and it's working fine. You're just not going to be able to take a lot of cases. So let's talk about when we need Ceph, when we need CBCT, and ultimately this is going to come down to your own Dental Practice Act and the way you practice. So I'm just going to speak from where I practice and how I practice. So for me, I was trained on traditional PanCef. We didn't have CBC, so I mean, I'm fine with that. I mean, it works for me. Pano, obviously, you can use FMX for your ortho cases, but you're missing pieces, right? And there might be pathology hiding in there. So I strongly recommend at least kids should have a pano because we got to be able to see. You don't know how many cases I've seen, as second opinions or train wrecks that they were diagnosed off of FMX and then turned out there was things hiding in there, impaction, odontomas, pathology, extra teeth, mesiodents that were outside the field. And oopsies, guess who's liable? That doctor. Yeah, they had an FMX, but they didn't do a pan, which is fine until it's not fine. So yeah, that I don't recommend that, especially on kids. But even on adults, there's so many adults where we find things they had no idea they had. So I don't know. That's just my opinion. So as far as the whole liability thing of if I take a CBCT, do I have to read the stuff that's not that? You know what? If you're not sure about that, get yourself trained up. I'm not reading all the pathology for you. That is not I'm not an oral radiologist, nor do I read your stuff. I just read your stuff for ortho. So and I just tell you how to understand it, then you do it. Um, yeah, I mean that's why we use beam readers for a lot of stuff. We let them scrape the whole thing for all the other stuff, and then we just let the patients know, and it's their job. If there's stuff that's cardio or other stuff that has nothing to do with dentistry, we're gonna let them know, and if it doesn't affect our dental, we're gonna proceed, but we're gonna let them know in writing that this is going on. It's their choice. If they need to go get stuff done. So that's kind of my thoughts on that. Again, check out your own Dental Practice Act, your own laws in your own state or country. Um, if you're seeing kids that are growing, yeah, you got to have a Ceph. There's no way you can. If you have a big CBCT, you can get a Ceph from that. That's what I'm getting at. I have so much content on this. This is not hard. There's a way you can stitch it together. I mean, it's a little bit janky initially, but you'll get it done. So as long as you have a CBCT, there are ways to get a Ceph out of the CBCT. Contact beam readers or equivalent. Contact your company that makes your Ceph machine. You'll work it out. I've got every doctor that ever wanted to work it out has worked it out that I know. So, no, can I do that for you? No, because I'm not in your office, but you'll figure it out. So, whereas on the flip side, if you only have a PanCef machine and you needed CBCT functionality, you don't have it. So, if you have a big enough FOV, you can get everything you need from that machine. So, let me explain it to you a little bit more. And no, I'm not a tech whiz. So, of course, I'm reading this online. This is just coming from Gemini. Okay, AI. Okay, so they are saying navigating the purchase of high capital radiology equipment is one of your most critical and clinical business decisions, whether you're a pediatric dentist or a general dentist. If you're a primary care provider evaluating whether or not to invest in a standalone 2D PanCef or a specialized traditional Ceph unit or a large FOV cone beam CBCT, the choice impacts your workflow liability and youngest patients. That is true. Here's the essential pros, cons, and regulatory landscapes. Okay, option one. They recommend large FOB CBCT with low dose 2D reconstruction. Many manufacturers pitch the all-in-one solution by the large FOB FOV CBCT 15 by 15 or greater and use ultra low dose settings to reconstruct traditional 2D pan Ceph images. Pros: you can capture airway analysis, impacted canine locations, TMJ issues, and skeletal pathology in one machine. You have a single footprint, saves real estate in your office by avoiding separate machines. True 3D ROI provides uncompromised distortion-free 3D data whenever complex surgical or orthodontic interventions arise. The cons: artifact distortions. Reconstructed 2D Ceph images from a 3D are mathematically stitched. Remember I told you about that? They can suffer from pixelation, motion artifacts, and other stuff. Yeah, it's not that bad. I've seen them. Big upfront cost. Oh, expensive. Okay. Option 2. By the way, they said it's somewhere between 90,000 and 150,000. I don't know if that's true. You'll also need software licensing and specialized training. So that's kind of like what your oral surgeons do and some general dentists do as well. Option 2, the dedicated 2D digital pan Ceph. So this is a digital pan Ceph. This is what most ortho offices, it's half-half. I don't know. Some have that, some have the full thing. I think it depends on if you're doing surgical cases or not. You get pristine 2D metrics, fast scanning, and it's much cheaper, they're saying. Cons: you're going to have some blind spots. You're not going to be able to measure bone volume, cortical boundaries, or true airway boundaries. You cannot seamlessly upgrade to an FOV layer, so you can't build up from it. So that's a bit of an issue. Also, you've got the whole ALATA principle. It used to be called ALARA, but I guess it's now ALATA, as low as diagnostically acceptable. The ADA doesn't think a true CBCT should be a screening tool, is what they're getting at. So, the 2D might be better, is what they're getting at. Okay, so, okay. Now, and then we've got the risk of the liability lawsuit trap. In the US, you are legally responsible for interpreting every single millimeter of data captured within your FOV. That's what I told you about. If you have a large 15 by 15 FOV to view an impacted tooth, you also capture the C-spine, the skull base, and the nasal sinuses. If there was a lesion or pathology in any of those other places, the skull, the skeleton, the C-spine, the sinuses. Now, this is neuro, right? This is neuro, this is ENT. You could have extreme medical malpractice liability. If you purchase a large FOV machine, you must factor in the recurring operational costs of sending these to a OMFR, which is what I was saying. I sent them to beam readers. Let's see. Okay, so that's the thing. So basically, what AI is saying. How do you decide? To buy the dedicated 2D pan Ceph if you run a high volume standard pediatric or orthodontic practice focused heavy on early interceptive guiding, simple arch expansion, routine tracking. It provides the highest patient throughput, crispest trace lines, and lowest radiation dosage. Zero tracking liability for incidental findings. If you buy a large FOB CBC hybrid, if your clinical focus is on airway, pediatric dentistry with airway, complex surgical extractions, clear line of surgical setups, severe skeletal disharmonies, ensure your budget handles. Final purchase recommendations. For the vast majority of primary pediatric dental offices, a dedicated 2D pan Ceph should be fine. Reserve the midsize or large FOB CBCT only if your specialized clinical scope demands routine skeletal pathology mapping. All right, so that's that. Now you know what they say to do. So ultimately, if you get the big kahuna, you're gonna have to find ways of getting it read so that you don't have liability. I ain't doing that for you. Not my specialty. It is gonna cost money. Sometimes people pass that over to the patients, but sometimes patients don't want to pay it. So tough call. You're gonna have to figure that one out. All right, thanks.